Thank you for joining us for the White House Conference on Women's Health Research. The United States has the best health research in the world. Yet women's health is understudied and research is underfunded, and so many of you have said this. And the United States economy loses $1.8 billion in working time every year to menopause symptoms that upend women's lives.
But let me welcome back to the stage Julia Manchester from The Hill newspaper, thehill.com, Katie Schubert, who is the president and CEO of the Society for Women's Health Research, Linda Goler Blount, she is the president and CEO of the Black Women's Health Imperative, and Robert Egge, the chief public officer of the Alzheimer's Association, for a conversation on women's health issues. Please welcome them all.
Thank you so much to the three of you for joining us. I'm really excited about this panel talking about women's health. Katie, let's start with you. As you heard in that opening clip from Dr. Jill Biden, women's health is obviously understudied, and research underfunded. The Biden administration, we know, made some progress in this area. Where do we stand with the Trump administration?
That's a great question. I think we're still trying to figure that out a little bit, right? And sort of as we now have an NIH director in place, an FDA commissioner, sort of trying to thread that needle a little bit. But this really was almost exactly a year ago today. The Biden administration announced an executive order related to women's health research because of all of those reasons that we just heard. And so we've never seen that level of national attention before. We've been doing this for a long time, and we're going to continue doing it. The need is there. But I think there's a great opportunity for us to sort of think about how do we continue this investment and continue the great sort of partnerships that we've all made to make sure that we're really pushing forward women's health research.
Linda, sticking with the Trump administration, we know that the administration has really zeroed in on dismantling DEI, diversity, equity, and inclusion. And I understand that you've had to make some changes at the Black Women's Health Imperative. What have the last few weeks, or I should say last few months, been like?
I think the last few months have been an exercise in flexibility and frustration management. We are a CDC grantee, and for a while our funding was hung up, and it wasn't clear that we were actually going to get the funding. We, as an organization, would have been fine, but our grantees at the state level were the ones who were going to pay the price and suffer. They were already talking about laying off employees. We have since gotten the funding, but what's interesting is sort of back-channel communication from our program officers were, as you apply for the next iteration of this grant, the next year, here is a list of words to remove. And, as the Black Women's Health Imperative, it's kind of hard to remove the word black. It's kind of hard to remove the word women.
Yeah.
And so we just proceeded in accordance with our mission. We will see what happens. We'll see if we get renewed. But we can't not be the Black Women's Health Imperative and serve Black women.
Yes. Right. Robert, I want to ask you, and switch gears just a little bit about Alzheimer's. It's a disease we've talked about quite a bit today. We know that our friends at the Alliance for Aging have talked about it. Women are more than 2 times more likely to develop Alzheimer's than men. Why is this, and sort of what is being done about it?
Yes, it's an interesting window into these issues broadly. The way you can explain this, first of all, the major point is we need to find out more so we can say more definitively about what I'm about to say. But there are 3 components we can point to. One is demographic. Women live longer than men, and over time that has some impact. A second reason is probably social reasons and things like that. For instance, of the generation now that's at most risk for Alzheimer's, there tend to be less education for women at that point as you roll back in time, and that we now know can have an impact. So that also accounts for a share of this double risk for women. But the third element is probably biological. And we see just this month more research that has been published on this front with, for instance, the impact of menopausal hormone therapy. And that indicates to us that that's probably the largest share right now. But we're still at a point where we can't say things definitively. We need to be able to do that.
Linda, it's interesting because oftentimes when we compare men and women, if you look at the women group in that subset, oftentimes Black women, women of color are more likely, or face different risks than white women do. Moving back to DEI or to diversity, equity, inclusion, I guess how does the DEI play a role in health outcomes in the United States?
Well, DEI, diversity, equity, and inclusion, is one way of looking at data. So the fact is that not everybody experiences disease in the same way, and some populations are disproportionately, differently, or distinctly impacted by disease. So if you look at Black women, I mean, we're all familiar with the statistics about obesity and cardiovascular disease and diabetes. These are not due to race. I mean, there's no biological or genetic determinant to race. These are in large part due to our body's response to environmental stressors, to the lack of health care, the lack of health insurance, the lack of a livable wage. There are all of these things we call the social determinants of health that impact our health. And one of the questions that could be answered through DEI is why the social determinants of health exist. Because sometimes we take them for granted. Well, that's just that. But it is, in fact, how the system is organized. So if we actually looked at the data, prioritized the health and wellness of all populations, but looked at what impacts different populations differently and distinctly, and addressed solutions from that perspective, then we could actually talk about elevating population health. And getting back to the previous speakers who said, in this country that spends the most on health care compared to any other country, has the best health care to offer, we could all actually be significantly healthier.
Katie, I want to get your perspective on the changes we've seen in DEI. You work in women's health care. I guess, how does DEI impact women across the board?
Yeah, so I mean, if you think about women in general, right, we're 51% of the population, and I would argue that we probably need to understand the effect of drugs, therapeutics, devices on the population in which you're trying to treat. And up until 1993, women were excluded from clinical research at the NIH. And so that was not long ago. So I think from the perspective of making sure that there are diverse populations included in research and that access to care and healthcare treatments are equitable, I think that makes a lot of sense to be thinking about how we do that. And so, if it's a matter of the language, that's one thing. But the reality is, again, going back to the data, if you want to find solutions, you need the data, and you can't have the data unless you're looking at these populations. And so I think it sort of all is coming together in that way. For women in particular, obviously, the diversity of women, right? We are not all the same, just like men and women are not the same. You need to make sure that you're really looking at what the population is that you're trying to reflect.
Right. Robert, one thing we've talked about quite a bit today with some of the lawmakers and other experts that have been present are the NIH cuts we've seen during the Trump administration. We know that there was a lot of progress made at the NIH on Alzheimer's funding, Alzheimer's research. How have those cuts, I think I know the answer to this question, how have they impacted that research? Where do we go from here?
It's been very disruptive. We know that every time there's a new administration, there are pauses and things, and maybe that could explain the first few weeks, but clearly we're well beyond that. On the other hand, we have the commitment of the incoming NIH director to provide the resources we need, and we'll look forward to working with him very much on that. And foundationally, we have Congress, which had just hit with a continuing resolution, which in some regards is disappointing because there's things that we see more opportunity for with more funding for biomedical research. But nevertheless, it showed a reaffirmation from Congress at that level. In that sense, there haven't been cuts. On the other hand, for particular grants, and particular programs and what you may have heard about as indirect costs that go to universities, all those things, even if the overall pot of money is still stable, those kinds of changes really disrupt the pace of progress, and it makes it very difficult to plan, which may sound like a somewhat trivial issue, but it's not at all if you're thinking about, for instance, how many new trainees do you bring in a new medical cohort. All these things really matter, and right now have thrown people off when we have to be as fast as possible in moving ahead.
You know, I want to pose a question to all of you. I was chatting earlier today on stage with Congresswoman Kim Schreier, who herself is a pediatrician or a primary care doctor, excuse me, and she was talking about how a lot of young students, medical students, it's a pretty bleak time for them going into, or researchers going into healthcare. You know, I want to hear from all of you, what's a pep talk you found yourself giving your teams about how they should navigate this environment?
Positivity, right? Yeah. Actually, this is something that came up, and we were up in New York recently, and there were researchers in the room, and they were researchers who were pretty young in their career, and they're looking at things like sex differences. And already that's sort of a small piece of the research ecosystem, and they were asking this very question. They're very concerned about their own health and well-being. They're concerned about how are they going to survive in terms of, making money, a place to live, et cetera. And I think from our perspective, it's about gathering those stories that we can then help to bring to Congress, I think, at this point, to really talk about the impact of this, not just on the research discoveries that we're seeing made, but truly down into sort of the trickle down of the economy in local communities, because it's not just about an NIH grant that's going to a particular researcher or institution, it's the entire ecosystem and community that we're seeing too. So really trying to stay in it, we're here to help, and let's figure out how we can really help you navigate this and make sure that we're keeping this research going.
Yeah, at a recent all-hands meeting, I said to the team, look, this is what we do. We are not going to back away from this. We are not going to be deterred by this administration. And I reminded them of the incredible work that we've accomplished. We got the PALS Act legislation passed that protected screening, breast cancer screening at 40 for Black women. That saved 1,300 lives every year. We're CDC's top-performing diabetes program. We have launched the first ever study on breast cancer in Black women to finally answer the question of when Black women should start screening and how often. So I keep coming back to think about the incredible work that we've done and the fact that we're the ones that we're working for, the very staff. And in terms of care, since we were founded as a self-care organization, I also encourage the team, one of whom is here, take time when you need it. This is stressful. It's going to get more stressful. So just take time. We have got to practice what we preach as an organization to ourselves.
Robert, what about you?
Now, one thing that was striking to me, talking with researchers recently, has been the fact that in Alzheimer's, if you went back about 10 years or a little bit further, you'd find that we are 1/8 the size of funding that we have today. And in those times, people were discouraged. You often hear stories about seeing leaders of labs advising their promising students to go elsewhere because you could not make a career in Alzheimer's research. Today, some of them have said it feels the same way in these months, that they're still wondering about their early promising researchers in their labs and what's their future. Yeah, I think the administration has a great opportunity right now, Dr. Bhattacharya, to just have that consistency, that normalcy come back and to be reassuring. If that can be done, then we'll still have these disruptions, but I think it'll put people back on, again, better footing for thinking about their careers, what they want to do, because we can't afford to have people step away from medical research in academic settings in particular. It's extremely important to everything that follows.
Katie, we've talked about the government's role in all of this, but why is private investment in particular so critical for fueling innovation when it comes to women's health?
Yeah, I mean, the time is now, right? As we're navigating the broader challenges of the economy and federal investment. In women's health in particular, the investment is very small. It's between 8 and 11% of the NIH budget goes toward women's health, depending on sort of what sources we're using. But I think this is a good opportunity for us to continue, right, our North Star mission to make sure that we're getting women's health research out there and we're funding it and supporting it. But we've never seen, because of this conversation that's been happening nationally, more interest and investment from the private sector. So, looking at venture capitalism, which was only at 2%, we're hoping that will go up. Looking at the pharmaceutical industry, how can we help that investment? And really think about the healthcare ecosystem and the research, continuum as well. It's not just the federal government. I think it's an obligation of all of us to make sure that we're all supporting these efforts to keep the momentum going.
Linda, from your perspective, are you seeing more interest from the private sector because of the national environment we're seeing?
Potentially, certainly in women's health. Not as much in health disparities because of, again, it's sort of the profit motive that drives some of this research and development. I mean, since the Heckler Report in 1985, $200 billion has been invested in health disparities and health equity research and programs, and here we are. And I literally had a founder say to me last year, well, there's no money in equity. Well, in fact, there is money in equity, because if we address some of the very issues that Katie spends her time talking about and you spend your time talking about, we can actually improve not only health outcomes, but economic outcomes. So it takes that kind of investment. But if people perceive that they're not going to get that return or that big exit out of whatever the therapeutic development is, then that will keep them from doing that. We have to incentivize them and help them understand that so many people would benefit from whatever that great idea is that they have. And to Katie's point, we have to get more investment. 2% of venture capital goes to women's health issues.
Yeah.
That's absurd.
Well, and sticking with that point, I'm going to sidetrack a little bit, but with the Trump administration's actions on DEI, we've seen many private companies and corporations have seemingly, maybe towed that line. Are you seeing that from your perspective? Is it impacting people's perceptions?
It is, although I have not seen it impact the behaviors, but we've seen things change on a website, we've seen words come down, but from some major foundations and funders, what I'm hearing is we're going to continue to do the work. We had to take this off the website, but we're still going to fund you and fund these issues. But they've also said, could you change your language and say it this way, just to make sure that you get the funding. So I think, yes, there's a response at perhaps the corporate leadership level, but at the level of people making these kinds of decisions, they're still very committed to these issues.
Right. Robert, we talked about Alzheimer's, but you're also giving a lot of families with a family member struggling with dementia support. How is your group doing that?
So dementia support comes in a lot of different ways, and it depends on what families can do themselves and what they depend on from state and federal government. There are two big areas. One area that we focus on a lot is making sure caregivers are equipped to handle the load that dementia brings. And it is one of the major reasons that we have caregivers today is for those families with dementia. It's often people caring for their parents in these cases. And so one way we have to be thinking about this is what a benefit that caregivers are with their generosity, which they're happy to do, but it's such a stressful and difficult job in many cases, that they're doing this and the whole country benefits. So just in the case of Alzheimer's, again, we have the case where there's about 11 million people providing care to those with dementia, volunteer, unpaid care. That's equivalent in terms of what we're paid to $350 billion per year. So if you think even in proportion of just that one disease to what's being talked about in Medicaid, you realize that when we make these decisions, whether it's caregiving for those young or old, we have to make sure that this infrastructure is in place or we're all going to lose out. Our system, and although it's often invisible, depends on caregivers. And so to your question then, that's something that we are laser focused on, the Alzheimer's Association, is what can we do through advocacy and our direct support to make sure that caregivers are equipped as best they can be for these difficult jobs. And
when you mention caregivers, obviously there's people that come to, patients' homes and such, but are you also referring to family members, to, the children?
Exactly right. Yeah, I'm glad you asked, because that's exactly who I'm referring to. Our families primarily, not only, but primarily families. Sometimes it's a spouse, sometimes a partner, sometimes it's children, adult children who are taking care of parents. It can come in all different ways, and sometimes it's friends. But that's who I'm referring to with those stats and how much we rely on this group of volunteers across the country.
Right. I want to pose another question to all of you. I guess, what are your biggest advocacy priorities? I know that we've sort of touched on them a little bit, but wanted to give you all a chance to go maybe more in depth. Katie, I'll start with you.
Sure, and I think this is fluid, right, depending on sort of what we're looking at. But I would say, in spite of the sort of federal funding environment, making sure that we're continuing the momentum surrounding women's health research and ensuring that sex differences research, so really looking at those biological differences between men and women from the beginning of your research. That's going to be really critical. The offices of women's health, which were established in the 90s and 2000s, those are something we're keeping a very close eye on across the federal agencies, and especially at the NIH, to make sure that women's health research is coordinated and prioritized across the NIH. So I would say those are really big ones, and then just really thinking about conditions that differently, disproportionately, or uniquely impact women, which is many, many things, right?
Absolutely, Linda.
Yeah. And similarly, there are offices of minority health throughout the government and HHS. There's the National Institute of Minority Health and Health Disparities. We're watching to see what happens. If tomorrow it was announced that it's being defunded, nobody's going to be shocked. But we're watching. But from a policy perspective, we also have to look at maternal health. Obviously, we know the rates of Black women in maternal health. Getting HEDIS measures, quality measures, to make sure that providers provide good health. Obesity-related diseases, we're looking at what's happening on the therapeutic side with GLP-1s and access, and who doesn't have access, but also what we're doing broadly around obesity. And of course, reproductive health and rights. I mean, this is sort of our heart and soul. And so we have to be very aware, and we're engaged at both the federal and state level on these unceasing attacks on reproductive health and rights for Black women.
Robert?
Yeah, so a lot of similarities to what's already been said. A lot of what we're focused on right now is just navigating these months and advocating for what needs to happen and things we've talked about in this discussion. As we look ahead to the reconciliation conversation, there again, for Medicaid, we're making sure that we're speaking clearly about those vulnerable elderly people, in particular in the case of Alzheimer's, dementia, that rely on Medicaid so much, and how we have to take great care in how we pursue these conversations and what proposals come forward and what impacts they'd have. Also in the reconciliation bill is we were so pleased to partner with AARP and others on the Credit for Caring Act, which is a tax credit that would provide caregivers with some of the support. It's extremely expensive what they do, and that would be very timely. We're encouraged that as bipartisan support on the Hill, and also the president on the campaign trail had mentioned his support for this as well. So we think things could align for that important step forward for caregivers.
I remember the president bringing it up, and also the former vice president talking about the sandwich generation. Yes. I remember her saying that a number of times on the campaign trail. Thank you so much for all of you for joining us today. We really appreciate your time. It was a great discussion.
Thank you. Thank you.
Julia, thank you. What a superstar. Great job. Thank you all. Just a couple of housekeeping notes. First of all, there's a QR code here. We want you to sign up for the National Pharmaceutical Council for your weekly Tuesday updates on the biopharmaceutical industry. And I mention that because they are providing the free lunch, so we thank them for that. Dr. Bobby is still here. This has been a great program, but none more inspirational. So please stand up one more time. Good luck to you. Thank you. We need your leadership at the AMA, and we welcome you back for the next 30 years. So stay healthy and stay well. Thank you very much. I want to thank the team here at the Hill Events, and the tech team, and also one of our lead sponsors in all of this, of course, the Alliance for Aging Research, and to Sue. Thank you all for being with us. We'll be back again in October. Enjoy the lunch. Have a great afternoon. Thanks again.